Welcome to A Sense of Hope podcast with One Life. I'm your host, Helen Diveston, and today we are talking to child psychiatrist Dr. Davin Tan. Davin is a dedicated dad and a youth forensic psychiatrist with a passion for empowering parents to help their anxious and sensitive children navigate the complexities of modern life. With over a decade of experience, Dr. Tan has become a trusted voice in the field, known for his empathetic approach and practical advice. He hosts the Parenting with Huddle Wisdom Podcast, where he explores the power of empathy, connection, humour, and courage, offering valuable insights and tips to support parents on their journey. Outside of his professional life, Dr. Tan is a proud father, martial artist, noodle connoisseur, and an avid reader. He enjoys spending quality time with his family, exploring nature, and experimenting with new recipes in the kitchen. His down-to-earth demeanour and genuine care for children's well-being make him a relatable and inspiring figure for parents and professionals alike. Welcome, Davin, to the Sense of Hope podcast.
Thank you so much, Helen, for inviting me. I feel very privileged and I'm very excited to get into the conversation.
Fantastic. The first question I have for you is why or what drew you into psychiatry? What was your journey like and why did you choose to be a psychiatrist?
I think I was talking to a friend about this actually last week. He's a surgeon. And we actually went to Africa together for our period of time where you can go and explore different specialties. And so me and him and another friend, we chose to go to Africa. This was our last year of medical school. At that stage, I hadn't quite decided what what I wanted to do. But I think after that experience, I decided that I wanted to become a psychiatrist because through a process of elimination, I figured out that medicine and surgery, you actually have to work quite hard. And I thought, I don't want to work that hard. But I do like talking to people and I do enjoy listening to their stories. And then when I got back to New Zealand, I did a run in psychiatry with a great psychiatrist who's very down to earth and just, is just lovely person. And I love the way he worked with people who, people would classify as marginalized, different, and, people that you wouldn't necessarily want to hang out with. But he hung out with them. He was not like the other psychiatrists on the ward. They all wear suit jackets. And I thought that was a bit weird. But this guy, he was, t-shirt and shorts, and he would hang out with the patients in the courtyard, actually talking with them, whereas the other shrinks, they'd kind of just be in their offices. But I just thought, man, I really like this guy's approach. I thought maybe I could learn something from this guy because his patients were doing really well compared to the other ones. And I thought, wow, these patients are actually listening to him. They trust him and they like him. And I found that the stories that the patients was quite intriguing. So anyway, and then I signed up for another run of psychiatry. And then, cut a long story short, I ended up training in psychiatry and that's how I got into it.
It sounds like the psychiatrist was a role model for you.
Very much so. Yes, very much so.
And we need those in medicine, I think, because as you say, there's a wide variety of quality, perhaps we could say, in our health professionals. And so finding someone that you could inspire to sounds like that was a really powerful influence on your life, on your direction, actually, and your life, because, your work kind of is your life at the end of the day, isn't it?
Yeah, it really was. And I think what he showed me was that there is actually a way to practice psychiatry or medicine that it doesn't mean you have to block off parts of yourself. You can be authentic. You don't have to hide from your patients. In fact, I mean, obviously, some things should be kept to yourself, but for the most part, I think people do like psychiatrists who are trustworthy. And how do we get to trustworthiness? I think you have to be real. And if you're hurting, I don't think it's a bad thing to tell your patients that you're hurting as well. But of course, you should probably follow that up with, well, I'm hurting, but this is how I'm dealing with it, and this is what I'm doing to sort that out. And that's what this guy did with his patients. And I think it really resonated with people, the way he would talk openly about his own difficulties, but that did not hinder his effectiveness at all. In fact, I think it enhanced his effectiveness as a psychiatrist and a human being. It was amazing, actually. Yeah, so he really inspired me.
I mean, I think the way I was taught and the way that medicine has evolved over the years has been very much a relationship of the doctor is up here and is the expert.
Yes.
And the patient is down here. And for people that are listening to this, one hand is up and one hand is down, as you can imagine. And it's very much a power imbalance in the relationship. And we do, I mean, there's something about we've been taught to remove the humane side sometimes, or the human, maybe not the humane, that's a bit harsh, but the human side to us in psychiatry. And I think there's reasons for that, boundaries, and we need to have strict boundaries and all that sort of thing to work with. But in doing that, we have removed so much of the humanity in psychiatry and medicine.
Yeah. I agree with that. And I think people know, people can see you're not being real if you're hiding. I think people are smart enough these days to know when you're not being genuine, and they can tell if you're just doing it for other reasons apart from serving. So yeah, I agree with you. I agree with you.
So what was the journey like for you once you became a psychiatrist, or even perhaps a registrar in psychiatry? What was that journey like? You had this sort of inspiration, you had this way that you inspired to be. What was the actual journey like for you?
I'd say that there were ups and downs. I had my own experiences of depression, panic attacks, burnout, and I felt very much like a fraud, one doing psychiatry, and the job being trying to help people who have depression, anxiety, panic attacks. And I'm not supposed to feel depressed or anxious. I'm supposed to be the one giving advice, good advice, hopefully, but then I'm not following my own advice. And so I think that was sort of in the first 5 or 6 years. I think I got quite disillusioned with medicine, and while I was enjoying psychiatry, more so I think talking to people and listening to their stories, I don't think I was prepared for the legalism, or that experience of to watch your back, and you having to toe the line, you having to do what everyone else is doing.
Would you say it's a very rigid model?
Yes, I would say that. Yes. Yep.
Yeah.
I would.
And just your own story of, you had your own struggles with some mental health issues or depression. And to me, I'm like, oh, so, welcome to being human, because this is what we know. And I think the latest research from that Dunedin study suggests that something like 86% of people at some stage in their lifetime will experience a mental disorder that would be diagnosed as a mental disorder if they actually went, to their GP. But of course, most people just sort of struggle on their own. 86% of people. So having a mental health issue is more common than not in a person's lifetime.
Yeah. Yes. And to add to that, I've had some conversations with other colleagues over the last 2 or 3 years, or maybe even more, that we're all noticing an increase of complexity in young people's presentations. There's a lot more intensity to people's emotions, and the severity of that experience, and also the things that people are doing that's probably not very healthy for themselves in terms
Mm-hmm.
of, self-harm or substance abuse. It seems to be increasing quite a lot in terms of volume and severity. And I don't know if you saw that as well, Helen, from your end. But
Mm-hmm.
yeah, so those statistics that you just quoted, I believe it. We see it.
Mm-hmm.
We see it.
Mm,
Mm,
mm. When I went back to work in mainstream psychiatry a couple of years ago, that was one of the things that was regularly discussed, that the complexity of
yeah.
the people that we were seeing was
Mm,
much more significant. A lot of social issues, but a lot of complex mental health issues as well.
yeah.
And of course, we've got the physical health issues that are often connected due to maybe the medication that people are on. So
Yeah.
it's a lot to cope with and deal with as a
Yes.
psychiatrist, and perhaps multiple people involved in their care. So
I was going to say that, there's been a lot of media coverage lately about how under-resourced mental health services and health services are. And some colleagues would, I think with the right intention, they would say, we need more funding, we need more psychiatrists, we need more of us. And no, because there's no way that psychiatrists or mental health professionals are going to stem the tide of what is here and what is coming. There's too much. So we need a different way of solving this mental health crisis.
100%. Yes. I mean, that's how I feel too. Whenever I see something on the news, oh, we need more money for more counsellors, more psychologists, more psychiatrists. No, we need a completely different model of care.
Yeah.
Which, interestingly, I understand you're doing, and we'll talk about that in a minute, but because we need to start from childhood. In fact, we need to start probably from antenatal care, in my mind, to develop
Yes.
people with good, solid mental health.
Yeah.
So I 100% agree. Oh, it's a challenge, isn't it? I think if you feel very strongly about this, to be in like you say, a very rigid organisation that thinks that, no, we need more money, we need more counsellors, we need more psychiatrists. It's a frustrating model to be working in.
It really is.
How did you move from the mainstream, how and why maybe, did you move from mainstream psychiatry into what you're doing now? Because this sounds like it's quite a different model.
So I did a lot of my training in Auckland, and then I did a lot of it in the Bay of Plenty. And then after I qualified, I scarpered off to Australia. And I worked there for a couple of years as a child psychiatrist, and then came back to New Zealand and worked at the regional youth forensic service in Auckland. So I worked there, and it was awesome. And I thought I quite like the forensic stuff. I like that. And so I decided that I would train as a forensic psychiatrist. I did that, and then I got bored again. And then I decided that I didn't really want to work at the DHB because I would probably get bored. So I decided to move into private practice. I've been doing it for 8 years now. And I do have these periods of boredom. But I think, the reason why I tell you about that is because I understood my journey as one of just a dude being bored and changing directions and stuff. But I think what I realize now is more that I was just dissatisfied with how things were done. We have these very cookie cutter approaches to treating people. And of course, no one fits the boxes. We have these manuals, these diagnostic manuals that says, if you have this symptom, that symptom, that symptom, or then you probably have this diagnosis. But I read a recent article that said that actually about 50% of those diagnoses, they overlap. And then we create these treatment algorithms based on experiences that people have that are so cookie cutter that it's very difficult for to think that it should be to work differently because of the way the system's structured and the hierarchies. And that you were saying earlier, the psychiatrist is at the top of but I don't think that's right. I don't think that's right at all, because I mean, what does psychiatrists know, really? So I think we need a different way of doing things. And I think that's why I jumped around quite a lot, because I was just always dissatisfied with how things were done. And then I moved in private practice. I mean, it's probably the longest job I've had, like 8 years now, private practice. I can just work with my patients. We don't need to worry about managers or other people breathing over our necks about whether what we're doing is correct or not, or within the treatment algorithm. Of course, I still do what's clinically
Required.
sound, but
Yes. Yeah. It sounds like you threw the DSM out the window.
yeah, yes,
Bad thing to do, I think. Yeah.
yes, not a bad. Yeah, yeah. Yes, I have to be a bit careful. I mean, I like
Yes.
to have some structure, but I think it's not it's not the on someone's experience. Yeah.
Yeah. I think over the next maybe 10 years or so, that psychiatry, along with perhaps the other sort of mainstream medical model, but psychiatry especially, is going to have to reinvent itself.
Yeah.
Because it's, in my opinion, I think it's a failed model of care. It's diagnosis, medication, if you're lucky, talk therapy, and yet, certainly from what I've read and the research I know and what I'm passionate about, there is so much more that we can do for people who are struggling with mental health. And even whether it's diet, exercise, socialization, support, all these other very important, getting people out of poverty, all these other very important factors that are involved in a human being well.
Yeah, absolutely. And I think more could be done to support parents and teachers. And actually, when my colleagues say we need more money, I was like, no, don't give it to us, give it to families and teachers. That's where our money should be spent. I mean, you alluded to earlier about those early stages of life being so critical. And I agree. I think that's when people set down real strong roots, or potential to set down strong roots if they have good connections with the people that care for them. They don't have to worry about, where I'm going to sleep, where am I going to find my next meal. So I think that's where the money should go. Families
totally.
and schools, not psychiatrists.
No. And we know that if we prevent children from adverse childhood events in those first few years of life, that would reduce the mental health issues and the physical health issues, actually, at the other end of the spectrum in their adult life significantly.
Yeah. Yeah.
How do you work that might be different from the average mainstream child psychiatrist?
I think maybe the point of difference is that I'd say, and I don't know if this is correct, but I'd say that my boundaries are probably more fluid. That's different to saying I cross boundaries, because
yes, I hear what you're saying. Yes.
So so for example, I have a few clients who are classified as marginalized. I would routinely take them to lunch because they would come to clinic hungry because they just spent their money on methamphetamine. And how am I going to do any meaningful treatment with them if they can't think?
Because they're not fed. Yeah.
They're not fed. So I take them to lunch, and we'd have food, and then we'd have a bit of a, corridor, and then I take them back to the clinic, and then do the usual thing where it's okay, well, let's have a discussion about what we should do now about whatever problem it is that he or she came to see me for. I don't know. I think I like to think that I like to go where people are.
Meet them with where they're at.
Yeah, I think so. I'm not always successful, but I like to try to mobilize the village around a person. Because I think if I was better at that, and if I had the time to spend all my time doing that, I think that would take care of a lot of the problems that came through my door. I think connection, the village, who's my tribe, where do I belong, strengthening communities. I think that's where it's at, Helen. So I resonate with what you said about psychiatry being a failed model. I don't think we're doing it right. I think we really need to be going to the community and working on strengthening communities. Not saying that people aren't doing that, but I think as a system, I think we need to be supporting that approach.
Yeah, it is a system approach, isn't it? And I know that they're bringing in health coaches a lot more, and I don't know if that's in psychiatry yet, but definitely in GP practices, really to work with that ground root area. So, going out and talking to them, I mean, it's often about diet and lifestyle, but it would also be about social connections and giving them that social support, or encouraging maybe group sessions, which might be more of a social support for people.
Yeah.
I just had a thought that actually it's a bit like going back to the olden days when I remember doing group sessions in the community mental health centre. And so it's almost like going back to that, where at least they had connections and they were making friends and they felt like part of a community.
Yes.
I don't know if we want to go back to the old institutions, but maybe there's some mid ground about safe places for people to be.
Yeah, I think so. What's that expression? We don't want to throw out the baby with the bathwater.
Yeah, we don't want to throw out the baby with the bathwater. Yeah.
I think you're right. Finding a middle ground is a good thing for us to try and do.
We've talked about perhaps what may need to change in psychiatry, and a different model, a different way of approaching mental health. There are so many layers, aren't there, to mental health and well-being too. We've got the mildly depressed person to the acutely psychotic, and absolutely everything in between.
Yeah.
And a cookie cutter approach doesn't really fit for many people. If we think about the predisposing factors that cause or contribute to poor mental health.
Yes, that's true. I've always struggled with categorizing folks to either have mild, moderate, severe issues. And I know what you're talking about. There's this misconception in private practice as well that we might only see mild to moderate cases, but I think people in the private sector are not any less complicated than in the public system. Sometimes it's hard to say someone has a mild problem. If they're going to work, they seem functional, but internally they just disconnected from everyone around them because they're just trying to survive. And so, but they're still going to work. And I'm thinking he's not connecting with his wife. He's not connecting with his kids. His kids are having problems because they're worried about dad, but he's going to work. So that means his problems are probably mild. And I'm thinking it's not really mild. But so again, our DSM, the diagnostic categories are really not. I think that they're missing the mark. I would think that he's actually got a severe problem, if I can give an example like that. So, but I think mild, moderate, severe. I think, as you were saying before, I think there are some really critical aspects to human wellness that people who have mild, moderate, severe problems can benefit from, like overall good nutrition, community, connection with your body, connection to people that you love and care about, and that that other people care and love you. Where you belong, sleep, all those sorts of things. I think, across the board, I think is really good for us.
So What do you think needs to happen in order for us to create a new model? Like what sort of boundaries or what sort of things?
I think that we make sure that we have the right people that actually want to work with other people. And then I think that we need a system in place that allows those people to work in the way that they do and have autonomy. And then we have to have a broad commitment to upskilling the community in terms of emotional literacy, the importance of connection at an early age, and then having the education system also be part of that community where we do away with siloed thinking, and we do away with hierarchies.
You're not asking for much there, Davin.
It's not much, no, no, but I almost think that I think we've had conversations about this before, Helen, that it's so hard to change cultures, and I think, I don't know, we almost have to let the current system deteriorate.
Yeah. You're not the first person to say that at all. I've heard this a few times, that the current model is slowly dying and perhaps it needs to die, and so that we can create actually a new model of care.
Yeah.
And it's interesting that you bring the education system up as well, because I think that they're somehow quite entrenched, that even in my mind, the education system also needs, I don't know, it needs to be remodeled somehow, because I think we've got our priorities wrong in education. It somehow feels once again that it's very regimented, it's rigid, it's structured, and there's not a lot of movement. There's not a lot of room for people that don't fit the mold.
Yeah. And even us talking about, this is health, this is education, it's kind of wrong. It's actually well-being. It's the it's the whole thing. Like, we need to it sounds so cheesy. It's like we all have to work together, but we do. We do. I really do think that part of it, as you say, or I think you, correct me if I'm wrong, Helen, but the way mental health systems are structured is around these hierarchies that have the psychiatrist at the top, and then everyone else in the bottom, and then that doesn't work. Like, we know it doesn't work, but we're still doing it. So it comes back to, I think the system just needs to deteriorate, and then interested folks have to come together to start doing something different. But how do we get legitimacy? Maybe it's I have no idea, but we have legislation working against that as well. So again, that cheesy line of, we all have to do it together and have the commitment and interest, and
yeah. Do you think it's going to come from the top down or the grassroots up?
I hope that it will come from the grassroots up, but I do think that we need people at the top to also recognize and realize that things need to be different, and to stoop down to the underlings. No, I think
no. This is good. It's great.
So I and have some humility. I think hubris and groupthink are massive problems in our system. We could talk about that a lot, but I think definitely grassroots, but people at the top supporting that, I think, is really important.
So here's a challenge for you, Davin, because we mentioned this earlier before we actually were recording, but this podcast is called A Sense of Hope podcast. not a sense of despair podcast.
Mhm.
So how do we turn this around, and what do you see that's positive that's happening out there, and what gives you a sense of hope for the future of psychiatry?
Well, I think this podcast being one, I think people like yourself and others out there with the courage and the interest to actually say, this isn't working. We need to do something different. But also, I think I do think that there has been something of a sea change where the voice of the people at the grassroots are being taken more seriously. But then how to translate that into real outcomes is a real challenge because of this current existing systems. So even though there's interest, which is actually a far cry from where we were years ago, where there was no interest. So it gives me hope that there are more and more clinicians like ourselves saying, actually, we need to do things different. And also, I think what gives me hope is that people feeling, maybe I can say, feeling more empowered to own their own health.
Yeah.
That I mean, psychiatrists, what gives us the right to dictate how someone should order their mental health treatment? I think we should be part of the conversation and we can give advice, but I don't think we should direct that. And I think there is a bit of a change where that's starting to become more, I don't know if the word is unsatisfactory, where actually the patient is having more of a voice and a say in what works for them. So that gives me hope, that and it gives me hope that there are people working in this way. I just hope that there's a lot more coming in the future, which I think there is.
Yeah. I think the wheels are slowly tuning.
Yeah.
And the more people, I think there's probably still a lot of people out there that know that something's right, but they don't quite know what it is. They feel a sense of unease, but they haven't yet found a new way of being. But I think there's now more coming together. I mean, if you look at sort of the Facebook page I run about the integrative medicine, for mental health, that's just slowly growing because more and more people are thinking, there must be a better way. I want to do things differently. And then we've got people like David Beaumont doing the positive medicine model. So he's another one that I think has just gone, hang on, things aren't working very well. What else can we do differently? We've got Precure, that have really are trying to redesign health and the way that we approach health and well-being. So I think you're right. I think there are more and more people coming up saying, we want a different model of care. And I love, I've talked about this a few times, is that the psychiatrist may be an expert in mental illness, because that's what they're an expert in, not even an expert in mental health, I don't think, but an expert in mental illness or psychiatric illness. But the patient is the expert in themselves.
Yeah.
We should be working as equals when it comes to best outcomes and where does this person want to be in 6 months, 1 year's time, and moving towards a model that's in alignment with that.
Yeah, absolutely. And I think having a system that supports that way of working is really important. Because that way of working is hard and it's lonely because you feel that you're going to get into trouble with the powers that be. So and I get it. Like, a lot of people just end up towing the line, which means you get substandard care. But again, I think there are more people willing to work in this way now, which is great to see.
Yeah, I mean, I totally agree with the lonely thing. If I approach doctors and say, "Hey, would you like me to come and talk to you about, how nutrition impacts mental health or
Yeah.
what we can do differently?" I just get crickets, and I know we're not interested. It is a lonely place to be, but there is, I think, like you say, the numbers are growing, and I think there's more and more
Yeah.
of us coming together.
Yes. Yeah, absolutely. And
Yeah.
clients or patients, because I'm not such a fan of that power differential either, because I think people have the resources in themselves. They might just need a bit of coaching to help unlock those resources. I try and send that message to the parents of the young people that I see. Because when they come and see a psychiatrist, because there's this culture of saying, "Oh, the psychiatrist at the top, he knows everything, he's an expert.
He's going to fix us."
He's gonna fix it."
Yeah.
And then when the psychiatrist says, "I don't know if I can fix this," and then, well, where do we go next? It's like, and then I'd like to say, well, you have the power to actually change things, and I want to make sure that people grow in confidence and strength and courage in the knowledge that actually sorry, I'm sort of getting on my high horse now, but like parents actually, they have that one thing that no one else has, which is that relationship with their child. And if they can somehow learn that, maybe that's not the right thing to say, but realize that actually that power of connection is so important. And then also trying to extend that network of connections outwards is the next step. But yeah, I don't know. I think people have this internal power that they don't realize they have. I think part of our jobs is to try and unlock that, rather than us being seen as the ones with the power, if that makes sense. Am I making sense? I hope I'm making sense.
You are so making, honestly, I want you on your high horse, because I think you've completely got it right. And I just agree so much that empowerment, and this is what I find so frustrating, is that person that feels disempowered, there is no hope. And by empowering someone and having their belief that actually they can do something to improve.
You've got what it takes. You've got what it takes.
Yeah, totally.
Yeah.
It might feel difficult or hopeless, but I don't think there's a person on this earth that can't do something that will help empower, that will help themselves if they have that tiny bit of empowerment.
Yeah. Yeah. Just a little bit of encouragement in the right way, and yeah. We speak the same language, Helen.
We do, Davin, we do. I think we could talk for a very long time, but we'll come to the end of the podcast for today. Thank you so much for sharing your wisdom. Is there anything else that you would like to say or add? And one of the things I often ask is there anything that you would like to say to someone that's perhaps struggling with their mental health, or even, a parent struggling with their children? Do you have any last words?
What I would say, try and remember the basics, and try not to think too much into the future or too far back into the past. What you have is now. Think about what it is you need to do right now. Not 2 minutes from now, not 5 minutes, not 10 minutes, not 20 years from now, but what do you have to do now? So get back to the basics. Can you connect with your body? How are you going to do that? Can you connect with your children? How are you going to do that right now? Which means, you might have to not think about all the million things you have to do for the day. But, right now, what can you do? If someone has depression, for instance, break things down. What can you do right now? You might not be able to get out the door because you're so depressed, which I get. But what can you do right now? Can you write some words of how are you feeling? So I would say, just think about what you have to do right now. Get back to basics. How do you connect to your body? Is there anyone you can reach out to? Who can you connect with? And if that's too hard, I say think about how you can break that down into really small steps, and just
Mm.
start there. I think just start in any way you can. Start
Yeah.
with small steps.
Yeah. Wonderful. Thank you. That's fantastic. How can people find you if they want to have a consultation with you, or you have a blog, I understand, and you've got your own podcast. So how do people find you?
So you can find me on LinkedIn or Instagram. I have a website, huddlewisdom.com. I've stopped taking on new patients for treatment, but I'm on those platforms now to try and empower parents and people who are struggling with their mental health by seeing how I can get them to recognize their own resources and then massaging that
Mm.
outwards and expanding that. So yeah, those are where you can find me. LinkedIn, Instagram, huddlewisdom.com.
Fantastic. Thank you so much, Davin, for being part of the Sense of Hope podcast. And it's been absolutely lovely talking to you. And I think there might be more chats in the future.
Oh, it's so great to be on. Thank you, Helen. I hope that I haven't waffled on too much and I haven't alienated anyone. Sometimes when I get a bit excited, I can run over my words a little bit, and sometimes it doesn't make sense what I'm saying. So I hope it's made sense to people.
I certainly have heard you, and I'm sure there'll be many other people that this will resonate with as well. So, and
Sure.
we love a little bit of passion. We need a bit of passion. We're so told to just, calm down and don't be so passionate about these things. But no, we need it. We need this passion because this is where we get our drive from. And this is what gets us up every day to do our job.
Yeah. 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 Absolutely. Well, thank you.
Yeah.
Thank you for those sentiments. And yeah, it's been wonderful having this conversation with you, and so great to be part of this project.
Wonderful. Thank you so much, Davin. Okay.
Oh, thanks, Helen.
See you later. Bye-bye.